Hello again, I'm Jamie. I'm a current F2 working at Guy's. For those that haven't met me before, thank you all for coming this evening. Just a couple of housekeeping points. So any questions that you have, put them in the chat rather than the Q&A, and because I've got the chat up, I can see them all on a live feed. And when you're messaging, make sure you put that you're messaging to everyone rather than just the hosts and panelists, just so that everyone can see your questions. Okay. So this week we're going to be discussing abdominal pain, another very common presentation in hospitals, and a particular interest of mine because I think I want to do surgery. So very broad topic, and as always, we'll start with our A to E approach. And I've done this a few times now, so I won't spend too long on this. I'll spend a bit more time on cases, as from all of your guys' feedback. So be systematic. Is people struggling? Anyone else struggling with hearing me? I can take these out. I might be able to. It might be better. Hang on. Let me put these away. People are struggling. I realise I don't actually need them. Perfect. Can you hear me now? Can everyone hear that? Okay, we'll crack on. Message if you can't. So yeah, systematic approach used particularly for acutely unwell patients, but you can use it in any scenario. It's used by all clinicians, from medical students all the way up to top dog consultants. And it's really good because it helps you remain calm, and it gives you a really useful way of assessing patients, both with regards to working out what's wrong with them and also working out how to treat them. Okay. Key points, as I said, be systematic, escalate early. If you're worried, particularly when you start as an F1, escalate early, get senior clinicians involved, and communicate really well with your nurses, with your other doctors, everyone who's there, to make sure that everyone's on the same page, okay, because it will help both you and the patient. So A to E, start with A, airway. This is what's going to kill a patient quickest. So when you go into the room, look and listen to see if there's any airway problems. Is it silent? That's particularly worrying. Can you hear snoring type noises? And then have a look to see if you think, are they lying in a funny position? Do you think the airway might well be compromised? If so, do not hesitate. Go straight in with a maneuver, either the head tilt chin lift or a jaw thrust. And to support that, if you then need to be doing something else, you can use airway adjuncts as seen here. So number one is the oropharyngeal, the Goodell. That's really easy and quite well tolerated in people with a medium GCS. Two is a nasopharyngeal, again, well tolerated, but the main contraindication is a basal skull fracture, so be wary in trauma patients. And three is an eye gel, or an LMA, and that is used as a more definitive airway. Okay, so it's very commonly used. And then also an endotracheal tube, which you won't be putting in, but that's what the anaesthetists are there for. Okay. The most important thing to mention about airway, if there's any concern at all about an airway, you need to put out a peri-arrest to get an anaesthetist there as quickly as possible, okay? Because they will deteriorate very, very quickly if there's anything wrong. B is for breathing. So have a look at the patient from the end of the bed. How do they look? Are they very cyanosed? Are they blue? Are they using all of their accessory muscles? Have they got sort of tracheal tug and they're using all of their neck muscles? Have they got a very high respiratory rate? look at their observations. So obviously that includes the respiratory rate, but their saturations as well. So have they desaturated? Are they on any oxygen? These are all very useful signs. And that's all before you even touched or talked to the patient, okay? Next up, examine them. So the obvious thing for breathing is to have a good listen to the lung fields, ideally both anteriorly and posteriorly, but often it's only possible to do it anterior. That's more just clinical judgment. See if they've got good expansion. Is it unilateral or is one side expanding more than the other? Have a good feel of the trachea working down from the thyroid cartilage. Is it central? And then percussion is very useful for differentiating between a hemothorax and or an effusion and a pneumothorax. Okay, a pneumothorax will be hyper resonant because it's air inside, so it'll be quite tympanic and loud. Whereas a hemothorax or an effusion will be much duller because it's liquid. Okay. And then depending on how concerned you are, get investigations. So if they've dropped their sats, probably get an ABG to see how hypoxic they are, as well as seeing if they're acidotic and what their carbon dioxide status is, and get a chest x-ray as well to look at respiratory pathology. And then if they're hypoxic, sounds obvious, but it's just worth reiterating, get some oxygen on them. If you're worried, 15-litre non-rebreathe mask. Otherwise, you can taper it down. You can just use a simple Hudson mask for, I think, sort of 4 to 8 litres. And below that, you can just use some simple nasal specs. And thinking about further management, if they're very acidotic and they're not able to blow off their CO2, for example, because they've got chronic respiratory disease, they may well need non-invasive ventilation. Okay, and that's when you need to think about getting some more senior clinicians involved. Okay. So next up is circulation, which is probably so what did we do? Last week we did hypotension, and the week before was chest pain. So with abdominal pain is similar. The circulation is probably the main focus of your exam. Okay, obviously if you found anything concerning before moving on to C, then you need to escalate and you need to treat it quickly. But typically C will be where you find your problems, and that will normally, in a patient with abdominal pain, could well be due to them being in some state of shock. So look at the patient. Do they look really pale? Are we worried that they've had a big bleed? Do they look sort of grey, waxy? What's their complexion? And do they look really dry? Looking at their mucous membranes in particular. Have a good glance at their OBS. Are they tachycardic? Are they hypotensive? These are all really useful indicators of what you need to do in the acute situation. And then when you're examining the patient, have a feel of their pulse. Is it regular? Is it got good volume? Can you feel it peripherally? Can you only feel it centrally? Have a listen to their heart. Do a good old fluid status exam to work out whether they're dry or they might still be overloaded if it's a medical patient. And cap refill time, which is something that's often forgotten, but is a really, really, really useful indicator of someone's fluid status. Okay, so if it's prolonged, if it's sort of 4, 5, 6 seconds, then we'll start to get quite concerned. All right, you can carry on with the rest of your A to E, but if there's any indication for it, I would get an ECG done. But before that, if you think that they are in a state of shock, get a cannula in, get 2 cannulas in, take some bloods off, depending on what you think might be going on. You can include blood cultures if you're worried about infection. If you think they might be bleeding, get a group and save and a clotting done as well. Okay, and then your routine bloods for all patients tend to be full blood count, renal function, CRP, and with abdominal pain, send some LFTs off as well. Okay, and then if they're in shock, if they're tachycardic, if they're hypotensive, get some fluids in them, try a bolus, and then you can follow up with some maintenance if it's working. If not, get some senior support. Diuresis will be unlikely in a patient with abdominal pain, but you never know. They might be overloaded if they're a medical patient alongside it. Okay, all things to have in the back of your mind. So disability, as always, I break it down into 4 things. So the first is their level of alertness. So if you've got time, you can work out a GCS. Otherwise, you can do a quick AVPU. Always get a BM for any patient. You know, even abdominal pain can be a sign of hypoglycemia or hyperglycemia, more commonly if they're in a state of DKA. If they're acidotic and they're really dry, patients can complain of abdominal, sort of generalized abdominal discomfort. Check the pupils, particularly if you're worried that they've had a fall or there's any trauma or any sort of confusion or intracranial event. And always get a temperature to sort of see if they've got a fever or which would indicate infection, and particularly sepsis if they're in a state of shock. And then exposure. So along with circulation, as I said, exposure is probably the most important one for abdominal pain. When I say the most important, I mean it's the one that you'll probably need to do the most thorough assessment. But it goes in the order A to E of how critical that is for a patient. Okay, so this is only once you've sort of gone through the A to E or A to D and you've fixed or are correcting problems, move on to exposure. So that is doing a good abdominal examination. Okay, so have a good feel, be very systematic in your approach, so that you can really localize any tenderness, or is it just generalized tenderness? Are they peritonitic? Okay, try and percuss to feel for an enlarged liver or an enlarged spleen, have a feel of their kidneys. Always try and feel for an aortic pulse in the abdomen. Is it particularly pulsatile, and is it expansile, making you think of a AAA? And if indicated, do a PR. It quite often is indicated in abdominal pain, particularly if they are unwell with it. And then also with abdominal pain, looking at any surgical sites, any wounds. Does there look to be infection? Are there any rashes? Does this patient have a central lining and an arterial lining? And then have a glance at the limbs as well, just to make sure that there's nothing going on there. And then, as always, after your A to E, reassess, go back to the start if you think it's necessary, or if at any point something changes during your approach, during your A to E approach, go straight back to A, okay? Because as always, that's what's going to kill them first, okay? Then have a review of what else is going on around the patient. So you can take a history from them if they are compliant and if you're not too worried about them. And with abdominal pain, it's really important, just like with chest pain. The history will give you a lot of information, okay? Review the notes. Why are they there? Have they had an operation? If so, look at the operation notes, see if it went as expected. Look at the post-op plan, and then look at their drug charts, look at their recent bloods and scans. Okay, it's all very useful to build up a picture of what's going on with this patient. Think about the escalation status. Is this an old, frail patient who wouldn't be for much? Is this a young, fit patient who might need to go to ITU imminently? And then think about further investigations and handing those over if you are finishing your shift. So, abdominal pain. As always with pain, just a question, what's the type of airway an anaesthetist would normally put in? So I'll just get back very quickly. So one is an oropharyngeal. Anyone can put them in. You put them in upside down, then rotate them. They're very easy. You'll do them in all the BLS courses. Two is nasopharyngeal. I've never used one. I've seen them used. They are actually used quite rarely. But again, anyone can put them in. It's just like an NG tube. Three, you can put in if you've been trained, and that typically is once you've done your ALS. And they're eye gels. You just need a bit of lubricant at the end, and they are easy to put in. and 4 is an endotracheal tube, which I haven't put on here, but that will be an anaesthetist because you need a laryngoscope in order to see the larynx and to find the gap between the vocal cords to pass the tube through. Okay. Great. So as always, Socrates, they teach it to you on day 1 of medical school, or maybe day 1 of clinical medical school, and it's really useful. Okay, and I still use it. I don't necessarily document in that format, but I still run through the questions when I'm asking them. But I still know colleagues and senior registrars who will literally write SOCRATES, okay, because it's really useful to make sure you don't forget anything, and also from a medical legal point of view, it just goes to show that you have a very systematic approach to what you're doing. Okay, so we'd very much encourage that. All right, and with the cases we'll work through. So with abdominal pain, it's like with chest pain. There's a wide range of differentials. Okay, and so with chest pain, it could be cardiovascular, it could be respiratory, it could be gastrointestinal, amongst other things, musculoskeletal. With abdominal pain, the abdomen is a very large area of the body. So we need to be a bit more specific, and that's what the history is important for. But typically everyone thinks that it's gastrointestinal cause, but do not forget that there are urological and obstetric or gynecological causes, as well as respiratory causes, such as a lower lobe pneumonia can often present with lower abdominal pain as it irritates the diaphragm. Cardiovascular causes, particularly vascular, so thinking ruptured AAAs or lower down type B thoracic dissections. Okay, and even pericarditis and myocarditis can present with sort of epigastric type pain. Okay, so really important to have a very broad range of what's going on. All right, and then at the bottom, I'll just put infectious diseases in there, particularly in kids. So kids with Epstein-Barr virus, so that's glandular fever, or and then tropical diseases such as malaria, cholera. All of those can present with abdominal pain and then and diarrhea and vomiting. Okay. So from your feedback, everyone said they like the cases most, and we've been through the ATE quite comprehensively the last few weeks. So I've tried to do it quite quickly there to give us some time to spend on these cases. So I've got 4 cases tonight, and unfortunately that's nowhere near enough to cover abdominal pain, but it's more to get you guys thinking about what could be going on. All right. So I've tried to do the format of this that, you get bleeped on the wards, but often it's easier to just say that you're an A&E or you're clerking, and this is the presenting complaint. What do you do? Okay, so there's a 19-year-old man in A&E who you've been asked to see. He's complaining of abdominal pain. He looks a bit unwell. All right. So the first thing to run through is our A-to-E approach. So the airway, we're not concerned at all. Breathing's fine. SATs are probably lower side of normal, so we're just a bit unsure, thinking that's not great. We could put him on a couple of liters of oxygen via a nasal cannula, particularly with a high respirator. It might just make them feel a bit more comfortable, but normal breath size from a respiratory point of view, we're not particularly concerned. Circulation, a 19-year-old man has a blood pressure of 99. Now, my blood pressure runs about 105 systolic. Okay, so 99 is not particularly unusual, but it could be. All right, and with a heart rate of 114, that's much more concerning. Okay, his cap refill time is prolonged, and he's a bit cool peripherally. Okay, but heart sounds 1 or 2 are present, and at this point, I think I hope everyone would think we'd stop here. We ourselves or a nurse would kindly put a cannula in, and we'd probably give a fluid bolus. Okay. And then while that's running, we can take off some bloods and send them for various things. If he's come with abdominal pain and he looks unwell, as previously mentioned, I'd probably send full blood count, U&E, so renal function, a CRP, as well as clotting, group and save, LFTs, and blood cultures. Okay. And then alongside it, I'd probably just put a little bit into a VBG syringe, and you can get someone to run that, okay, just to see what their lactate is and their bicarb. Okay. And then moving on to disability, BM's fine. 4.2 is a bit low, but maybe they haven't eaten for a while. That could all be, it's all just building up a picture of what's going on. GCS is fine. Temperature's 38.2. So this is a febrile gentleman, and pupils normal. Okay. So he has got a fever. He is in shock, and he's got abdominal pain. Okay. And he doesn't look great. So we've got fluids running, we've sent off bloods, there's a gas on its way. What are we thinking? What are our differential diagnoses for this patient? Chuck some suggestions onto the chat, guys. I'm hoping you can all still hear me. Yeah, 2 there, very good. Yeah. Okay, very good. So yeah, I'll work through those. Appendicitis, definitely number 1. Okay, young person with abdominal pain who has a fever. Okay, that's my first differential. Bleeding, very good. Can come with a fever, but it typically would be the fever that the cause for the fever that would then cause bleeding. Okay, so something like diverticulitis, where you get a perforation, you would have a fever and then you would get bleeding because they've perfed. Okay. Let me go back. Sorry. What else have we got here? Torsion, yes. You can get abdominal pain with torsion, very good. They're not typically febrile though, but good suggestion. A GI infection, yeah, very good. So gastroenteritis, food poisoning, all sorts of causes for that. Typically, quite often in the UK, you get Campylobacter infections, or C. diff if they're on penicillins, or clarithromycin. Yeah, urosepsis, very good suggestion from renal stones. I like that a lot. Is the abdomen hard? Yeah, sorry, I didn't mention it. Exposure, yeah. So when you have a feel of the abdomen, it feels quite rigid. Okay, it's you're at junior stage, you're not sure if it's peritonitic, but it doesn't feel soft. And when you're palpating, it's most painful in the right lower quadrant. Okay. So from that history, our number 1 differential is appendicitis. Now with appendicitis, with someone this unwell, it's quite easy actually. You look at the bloods, you have a feel of their abdomen, you take them to theatre. Okay. If it's a bit riskier, not risky, if it's a bit more uncertain, you can do a couple more tests. So you can do the psoas test, where you flex the hip and see if that causes pain, or the obturator test, which is where you internally rotate the hip in a flex position, and that can also cause pain. And you can do Rosvig sign, which is where you palpate on the left iliac fossa, and that will cause pain in the right iliac fossa due to irritation of the peritoneum. Okay. Can everyone still hear me? My camera's frozen, so I just want to make sure that I'm not just talking to myself. Just put on the group if you can still hear me. Yeah, perfect. Great. Thank you, guys. So yeah, you've had a feel of the abdomen. You can do a PR, depends on how much pain they're in. Okay. But always good to PR just to rule out lower GI bleeding. Fine. And then tests of peritonism. So there's 2 tests I do. One is rebound tenderness, where you pressing quite firmly into the abdomen, and then you pull your hand away very quickly, and that is rebound, and that will cause a real sharp pain, and that's a sign of peritonism, of inflammation of the peritoneum. The other one is percussion tenderness, so just percussing as you would on the chest, sort of causes ripples along the peritoneum, and that, if causes pain, is a sign of peritonism. Okay. So, and then our history, it's probably quite a barn door diagnosis, but we just want to work it out. And he'll probably say that he had some central abdominal pain yesterday that migrated to the right iliac fossa. He might have felt febrile, he might have vomited, he might have some diarrhea. The biggest sign that I've found in patients with appendicitis is that they are off their food. Okay. So something I'll ask them is, if I gave you your favorite meal in the world right now, would you want to eat it? Okay. And if they say no, that's quite a concerning sign. All right. Fine. And then, so this guy is septic. All right. Just because we've said it's appendicitis, he is septic. He's got tachycardia, he's got a fever, and he's got abdominal pain. It's probably appendicitis. It's sepsis caused by appendicitis. All right. So we've got a lactate being sent. We've sent off blood cultures. We're getting, put a catheter in, get a urine output, and give him oxygen, give him fluids, give him broad spectrum antibiotics as per trust protocol. Okay. So we've got this guy, young 19-year-old with what we think is appendicitis. What investigations do we want to do? So we've done the simple ones. We've done, we've sent off bloods and we've sent off a gas. Do we need any more investigations? What do people think? Yeah, group and save, cross match. Very good. That's what we've already sent them off though. Okay, I like these. So one suggested CT, someone suggested MRI, someone suggested an ultrasound. Okay. If we are convinced, and this is a pretty convincing history for appendicitis, in a young 19-year-old man who is fertile, he doesn't need a CT. An MRI is not cost effective because it basically, often it won't show appendicitis. And if it does, that's great, but we'll probably take him to theatre anyway. Abdominal ultrasound is a really good suggestion. And it's typically used when there's diagnostic uncertainty, okay? And mostly in women, okay? So if you think there is a gynecological cause over a gastrointestinal cause, or if you think that you should consider a gynecological cause, do an ultrasound to see if there's any sort of ovarian torsion or cyst. Is there an ectopic pregnancy? Okay. If this was a woman, really vital, any woman with abdominal pain needs a pregnancy test. Okay. But obviously no one suggested that because it's a man. So that's completely fair enough. But in this gentleman, he probably wouldn't get any imaging. He would get booked straight onto CPOD, and he'd go to theatre. Because he's septic, probably within sort of 6 to 8 hours, I imagine. But you'd want him there as early as possible. Okay. And it would be a diagnostic laparoscopy. Cool. Fine. Moving on. How are we doing for time? Okay. 1/2 doing pretty well. Next case, patient is seen in A&E with right-sided abdominal pain that is very severe, and let's say they're 50 years old. Okay. As before, A to E approach, as with anything, and airway's fine. The breathing is, you haven't found any concerns, normal breath sounds, their SATs are okay, their respirate's probably a bit high, but they're telling you they're in a lot of pain, so that's probably why. What do people think about their circulation? So heart rate's probably a little bit tachycardic, but the cap refill time's fine and they seem warm and well perfused. What do people think about that blood pressure? Is that concerning or not? Seems high. Yeah. So it is above what you would expect, but it's not worryingly high. Anyone got any suggestions why that systolic might be high? What have I said in the history? Yeah, exactly. In pain. So patients in pain, their blood pressure will go up. If patients are anxious, their blood pressure will go up. All right. And that is the most likely cause. And it also could be a cause for his tachycardia as well. All right. Although you need to rule out more sinister causes of tachycardia and than pain. All right. Nothing concerning on disability, and then on exposure, you want to do a good examination, and you want to do you want to take a bit of a history as well. Okay, so when you examine him, he's sore on the right side, but he's not particularly tender, and there's no guarding. He's not peritonitic. And the rest of the abdominal exam is pretty normal. Other than that, he's no previous surgery or anything like that. And then on the history, he states that this pain's on the right side. It's quite high up on the right side, and he said it's occasionally sort of radiates down to where his bladder is, or to his suprapubic region. Okay. So from that, what do we think? Any ideas about what might be going on? Probably gave it away there. Complicated UTI, yeah. Yeah, very good. So complicated UTI is a very fair point. Other things that you think about. So a pain that is in the sort of right sided, so the flank that radiates to the groin, so loin to groin, they say, tends to be the urinary system, and quite commonly it's renal stones. But yes, people suggesting pyelonephritis, very good. Complicated UTI, very good. Also, if it was a woman, I haven't said if it's a man or a woman here, sorry. If it was a woman, you'd think also have pelvic inflammatory disease in the back of your mind that could be secondary to an STI. Endometriosis, yeah, again, good, all good differentials to have in the back of your mind. Okay. But the nature of the pain makes it more likely to be urological than gastrointestinal. Okay, which is why the history is so important. So in renal colic patients, or suspected renal colic, or anyone with suspected urological disease, get a urine dip on them. And you'll find, so this man had traces of blood in his urine and a couple of white cells. And so from that history, you'd probably thinking let's get a CTKUB. Do we want that with or without contrast, the CTKUB? Okay, without, yeah, so good. You've all said without. One of you said without due to risk of renal damage. I really like that suggestion. If you're using contrast, you have to think about their renal function. All right. We don't know what this guy's renal function is. It could be horrendous. You're right. But actually, that's not the reason why we wouldn't do it without contrast. It's because we're looking for renal stones. And if you use contrast, you won't see anything. Whereas if you do it without contrast and they are opaque, they're radio opaque, which most, I think 90% of renal stones are, you'll see it, okay? And you'll see it very clearly, and you'll be able to quantify how large the stones are, which is very useful for management, okay? So this guy's got renal stones, and just a bit about renal stone treatment. Typically, when they cause this sort of presentation, they're either in the kidneys or they're in the ureter, okay? If they're less than 5 centimeters, often you can watch and wait, and the stones will pass. However, if they've got severe pain or there are signs of infection or renal damage, then you can just you can stent them. If they're a bit bigger, you can do something called extracorporeal shockwave lithotripsy, where you basically shock the stones from outside, so it's non-invasive, and the stones fragment and pass. Or you can, for bigger ones, you can do a ureteroscopy and collect the stones with a basket. And last but not least, you can do percutaneous nephrolithotomy, and that's typically for the really big stones, including for staghorn calculi. And that is where you go percutaneously, so directly into the kidney. So it's an antegrade approach rather than a retrograde approach, which would be up the urethra. You can, there's lots of different techniques to break the stone up and remove it. Okay. So that's just the management of stones. Okay. But typically they tend to get a stent that's removed either the next day or in a couple of weeks. And that's because after removal of stones or fragmentation of stones, you can get edema, which can actually block off the ureter. Okay. Would you do an abdominal ultrasound before sending to CT? Yeah, it depends on what you're worried about. If you're suspecting stones, send them straight to CT. If you are, if it's a bit of uncertainty, do an ultrasound, because it'll tell you if there's any other pathology, such as gynecological or any liver pathology, if it's on the right side. And an ultrasound will also tell you if there's any hydronephrosis, so it can grade how severe, sorry, if there's any backlog that's caused by a stone. Okay, and that's another indicator for intervention. All right. So case 3. Oh yes, this one. So you get a bleep from a nurse who's on a general surgical ward about a 73-year-old woman, so fairly elderly woman, who's got abdominal pain. Bit of a theme here. Airway's fine. Breathing is again fine. We're quite comfortable with that. Circulation's all right. Blood pressure's maybe a little bit sluggish, particularly a 73-year-old. She probably runs a little bit higher than that. And the heart rate's a little bit tachycardic. CRT's a bit sluggish, but heart sounds are present. Okay, so we think she's in a bit of shock here, maybe a bit volume depleted. And she looks a little bit pale to you when you go and see her. Okay. Only thing from D is that she's got a low-grade fever, and on exposure you notice she's got some tenderness in the left iliac fossa. No other tenderness, but she is quite sore down there. Okay. So what else do we need to do for exposure? So sorry, let's presume that we've given her a fluid bolus and then some maintenance fluids after this. We've sent all the bloods off because she's a bit pale. We've included a group and save and a clotting, and there's a lactate coming back as well, and some blood cultures have been sent off because she's febrile. So thinking about sepsis 6, because it's a febrile lady with who is in shock because of her tachycardia. So you've got left-sided abdominal pain and she's a little bit pale. What does this patient need? What's part of your exposure? What do you need to do? Anyone got any suggestions? Yeah, fluids, as I said, we need to give her a bolus and then some maintenance fluids along after that, depending on how she responds. Yeah, good. Infectious surgical site. Has this lady had an operation? Okay. So she hasn't had an operation, but good suggestion. And if she had, look at the wound. Does it look oozy? Is it bleeding? Are there signs of infection? Is there pus? Good. Fine. So yeah, we've done our abdominal exam and all we found is some left iliac fossa tenderness. Okay. Diverticulitis, very good suggestion. A vaginal exam, yes, in a 73-year-old. Concerning gynecological things, probably sort of ovarian cysts. It's less likely to be really major things like an ectopic pregnancy. Okay. So if she's on a general surgical ward, I'd probably rule out general surgical things first. Fantastic, Erica, thank you. A PR exam. This patient needs a PR exam. So they are tachycardic, they have a fever, and they are pale. They might well be bleeding, okay? Just because they haven't told you they haven't got any PR bleeding doesn't mean they don't have it. And actually that is very commonly the case. The nurses are pretty good at picking it up, but you never know. So do a PR, you do a PR on her with her consent and with a chaperone, obviously, which you will document both of those. And you find that she's got some quite fresh red blood, quite a fair amount in the back passage, as well as some pretty soft stool. Okay. So we've got a hemoglobin on the way, and actually one will come back from the gas, and the hemoglobin's from the gas is 85. All right. So it's low, but it's not something we need to worry about urgently. Although she'll probably need some blood at some point, particularly if this continues. But she's not in shock and in really bad shock, and her hemoglobin is not bad enough that we need to think about a major hemorrhage protocol. All right. So someone said it, diverticulitis is definitely the most likely cause in this patient who is febrile. They appear septic, they're quite elderly, and they've got left iliac fossa pain with some blood. Okay. This is what diverticular disease, and I'll go through the definitions in a little bit, looks like. So on the left here, we've got a flexi sig, which, as you can see, so in the middle, we've got the true lumen, but all around, we've got these false lumens. Okay. And these little outpouchings of the large bowel called diverticular. And then here on the CT scan, we're looking at the sigmoid colon coming down into the rectum, and these outpouchings here. I don't know if you can see my mouse. I hope you can. But these outpouchings are, again, diverticular, and this is diverticular disease. So just a couple of definitions here. So diverticulosis are it's the presence of the small outpouchings of the large colon, and this is typically in the sigmoid colon, although it can be anywhere in the large bowel. And then diverticulitis is inflammation of these diverticula. This is when a patient comes to you and they're febrile and they're tachycardic, and they've got raised CRP and raised white cells. Okay. So as I said, we sent these bloods off. This patient needs a CT abdo-pelvis to confirm the presence of diverticular disease and diverticulitis, and also to look to see if there's any collection or signs of perforation. If you're worried about them, get an abdominal film as well as an erect chest X-ray, because if you're worried about perforation, you can see air under the diaphragms. Treatments. The main treatment is fluids and antibiotics. Okay, IV antibiotics. In my last trust, it was Kermoxiclav, which we used, but just check your trust guidelines. And depending on the CT, they might have an abscess or a collection that needs to be drained. So you may need to liaise with the interventional radiologists about that. Now, what do we think about doing a flexible sigmoidoscopy on this patient? Because she's got PR bleeding. Should we do one of those? What does everyone think? Okay. Okay, someone said contraindication, someone said no, it can cause further damage or bleeding. Fine, why? Why don't we do it? Very good, risk of perforation, yes. And I'll go back. And the reason is because of these false lumens here, these diverticular. You can put your scope in if you don't trust where the true lumen is, and you go into one of these and you push your scope through it, you can cause an iatrogenic perforation. Okay, so we tend to wait, and these outpouchings are much more susceptible to perforation when they're inflamed, because the tissues are much weaker. So you would not do it'd be an absolute contraindication to doing a flexi sigmoidoscopy at this stage. You'll do it as an outpatient, and you'll get them back in sort of 4 to 6 weeks to have a look. Okay. Fine. So those are 3. We've just got 1 case left. What are we doing? Yeah. So we're doing well for time. Hopefully I'm not going too quickly, guys. I'm just trying to get through these cases to make sure that we go through them all. So this last one, sorry, any questions about any of those three cases, just pop them on the chat and I'll answer them as we go along. Sorry if I didn't say that before. So nurse bleeps you on the general surgical ward about a 56-year-old man who's got abdominal pain and is quite jaundiced. Turns out he hasn't actually been clerked yet. There's been a miscommunication. He's just come up from A&E. So there's a rubbish A&E clerking there, but nothing else is known about him. Okay. So as always, A to E. Airways patent, trachea is nice and central. His SATs are fine, although on the lower side of normal. His respirate is quite high though, 26, but his chest sounds clear. Systolic blood pressure is a bit low and he's slightly tachycardic. He's got a bit of a sluggish cap refill time. And his heart sounds are good. He's got a very high temperature of 38.9. But other than that, D is normal. And on exposure, he's got a very tender right upper quadrant. And he's very, very jaundiced. Okay, he's very yellow. All right. So I've seen some people have throwing out some ideas already. What have we got? Yeah, alcohol history for liver damage, cirrhosis, very good. Ascending cholangitis, I like that. Liver cirrhosis again, cholangitis. Someone said cholecystitis, fantastic. Okay. So this patient has what someone is correctly mentioned is Charcot's triad, all right? And Charcot's triad is the presence of jaundice with right upper quadrant pain and fever, okay? And this is indicative of a disease called ascending cholangitis, all right? Now, someone suggested cholecystitis, which I think is a very sensible suggestion considering they're febrile and they've got right upper quadrant pain. However, often you wouldn't get jaundice in cholecystitis. Okay, jaundice indicates well, jaundice can be prehepatic, it can be hepatic, and it can be posthepatic. Now, in the presence of right upper quadrant pain with fevers, it's likely that it's going to be posthepatic and there's going to be some sort of obstruction. However, you're right. This is just, someone said this could be liver cirrhosis. It could be hepatitis. Because you can get pain, you can get jaundice, you can get fevers with that as well. Although hepatitis often won't cause pain. Yeah, travel history and sexual health for hepatitis is very good. But bearing in mind we're on a surgical ward and they are in a bit of shock and they seem pretty unwell with a very high temperature. The number one differential to rule out is ascending cholangitis. All right. Now, so we talk about Charcot's triad. Does anyone know what Rigler's pentad is? So Rigler's pentad, Charcot's triad with two more features. Can anyone remember those? I'll be impressed if you can. So yeah, fantastic, both of you. So yeah, confusion and hypotension. So this guy has hypotension, is low blood pressure. We haven't mentioned his mental state, but actually it's all right. Okay. But yeah, Rigler's pentad again is indicative of ascending cholangitis. All right. So let's just talk a little bit about that. So jaundice, prehepatic, hepatic, posthepatic. Prehepatic typically is painless. And is a result of hemolysis, which can be for a number of reasons, and those are often hematological, so I won't discuss those here. It can be hepatic, so thinking about infection, so hepatitis, HIV, Epstein-Barr virus, CMV, or could be cirrhosis secondary to alcohol, or fatty liver disease if they're obese. Okay, or it can be posthepatic, which is an obstructive picture. And the easiest way to differentiate between all of these is in the bloods. Okay, so obviously you want a bilirubin. and they'll all be raised if they're jaundiced. That's what it is. It's the breakdown product of red blood cell, of hemoglobin, that causes jaundice. But then you want to look at the ALP, so the alkaline phosphatase, and the ALT, which is alanine transaminase. So ALT is typically, the ratios are typically higher for ALT in hepatic causes, and typically higher for ALP, so that's alkaline phosphatase, in post-hepatic causes, okay? And for post-hepatic, also consider sending off a GGT, gamma glutaminase, I think it is. But note that this can also be raised in acute alcohol intake, okay? So we're thinking this is post-hepatic. They've got a really high ALP of sort of 1,000. Their bilirubin's 300. They're febrile. They're really tender. They've obviously got this jaundice. We're very concerned about this patient. Okay, I've said, are you concerned? We're very, very concerned. And why are we concerned? Now, the answer is, like with any part of the body, we've got an infection here that is in an obstructed system, okay? And that means there's no outflow for the bacteria, okay? So there will be no resolution unless we solve that. So in the interim, they need IV antibiotics. Sepsis 6, they need IV fluids. But this patient needs decompression of their obstructed system. Like if you had a patient with a large ureteric renal stone that caused hydronephrosis and secondary urosepsis, that would need to be trained with a nephrostomy. This needs to be drained. And the treatments for ascending cholangitis, as I said, is IV antibiotics, but to relieve the system, the gold standard is an ERCP. Excuse me. So that you can drain the system into the bowel. But if they're not fit enough for that, either because they're very frail or because they are very, very unwell, you can do a PTC, which is a percutaneous transhepatic cholangiogram, and basically that's a tube through the liver, which through the ducts of the liver, which will be dilated due to the back pressure from the blockage, all the way down, and you can drain it there, and it'll tend to be frank pus. Now, these patients, ascending cholangitis is typically a gram-negative organism that causes it, most commonly E. coli. So you want to target that with your broad spectrum IV antibiotics, but can be caused by, I think, Klebsiella as well, commonly, and some Proteus. Okay, so speak to micro early as well. All right, so that's ascending cholangitis. Really, really worrying. Very, very concerning disease for any surgical senior. All right. And I haven't done a case about pancreatitis, but I thought I'd just talk it through with you guys. Pancreatitis, the ACE is vital. And as you might have noticed, all of the cases we've had so far, their airway and their breathing has tended to be all right. In pancreatitis, patients can become so unwell that they have such a large inflammatory response that they develop something called acute respiratory distress syndrome, or ARDS, which is quite similar to actually what we're seeing in COVID patients. And with that, they can get really poor respiratory compromise and need to be put on a ventilator pretty early on. And this can happen to really young patients, okay? So the A to E is really, really important for pancreatitis patients, okay? They present with epigastric pain that is eased on leaning forward, okay? Now, the causes of pancreatitis are, as I'm sure you are all aware, get smashed. So I won't run through them all because you can look them up. But the three that you should really have at the forefront of your minds when you're thinking about pancreatitis and you've got a raised amylase is the first two. So GE, so that's gallstones can cause it, and ethanol. So those are the two commonest causes of pancreatitis. And then the penultimate E there, the penultimate letter, the E in smashed, is ERCP. And I, on my last Gen Surge job, saw multiple cases of ERCP-induced pancreatitis, where the pancreatic duct was difficult to cannulate in the procedure and has therefore damaged the pancreas, causes release of the pancreatic juices, and that's what causes inflammation of the pancreas and surrounding area. Okay, so for any pancreatitis patient, you should score them using the Glasgow score, and the mnemonic for that is pancreas, and that grades basically how worried you are. So a score of 1 to 2 is not particularly concerning. 3 or more, you need to be worried, and 3 or more, you need to get an ITU opinion early on. Okay, even if they're not going to accept them, they need to be aware of the patient, because these guys really go off very quickly within a matter of hours. Okay, so I've written management here rather than treatment, because pancreatitis doesn't have a treatment itself. You can treat the cause. So, for example, gallstones, you could treat with ERCP and removal of the gallstones. But pancreatitis itself, you manage. It's all about managing the patient as a whole, and seeing how they are. And this is by getting them on an HDU or ITU setting if you think it's necessary, low threshold for escalation, get a catheter in, strict fluid balance monitoring, pump them full of IV fluids, particularly if they're young, because these patients get very, very dehydrated. They typically will need, quite often need sort of 6 to 8 litres early on, within the first 24, 48 hours. What else they need? Antibiotics is controversial in pancreatitis. Lots of my seniors would give them, particularly if they had raised inflammatory markers, because you can get a superimposed bacterial infection alongside it. Get a CT to see if there's any collection that needs to be drained by IR. So yeah, but it's management of the patient, and then get oxygen on them if they've got ARDS. You know, get them ventilated if you think it's appropriate, or if your seniors think it's appropriate. Okay, so just to reiterate, pancreatitis patients get really sick really quickly, and it's a fascinating disease because of that, and it's very poorly understood, but it's it can be very, very worrying when you see them. And this is just something I think I saw yesterday, which made me laugh, a bit more lighthearted, because obviously one of the main causes of pancreatitis is scorpion bites, that we all know about in our get smashed mnemonic. So yeah, but again, I will never see a scorpion bite as a cause of pancreatitis in my life, and if I do, I'll probably quit medicine and run mile.